Good evening, doctors. My name is Ankur Gautam, and on the behalf of FTC and my talks, I welcome you all to yet another episode of Diabetes Essentials with Dr. Sanjay Kalra. Today's topic is a very, very interesting topic. It's insulin with OAD combination. And today's session is brought to you by your zero calorie electrolyte in diabetes in Result Zero. Friends, now I would like to welcome our host to enlighten us regarding today's topic, Dr. Sanjay Kalra, Chairperson Education Working Group, International Society of Endocrinology, and past President, South Asian Federation of Endocrinology. Over to you, sir.
Good evening, friends, and welcome to this episode of FDC Diabetes Essentials. Today, we'll talk about a particular aspect of pharmacology which is quite challenging, but at the same time, which is quite rewarding as well. And today, we'll be speaking about how to combine insulin and oral drugs. Now, we all know that most people with type 2 diabetes will require drug therapy. Some of them will be well controlled on oral drugs, but this is usually just for a short period of time, a few years. Sooner or later, as per the natural history of disease, beta cell insufficiency will worsen, insulin secretion will come down, and sooner or later, insulin will be required. Now, in the past, we have spoken about oral drugs. We've also talked about insulin therapy. But today, let's talk about insulin and oral drugs together. Now, when we start insulin treatment, we have a choice. We can choose basal, basal plus, premixed, or basal-bolus insulin therapy. So let's see what drugs we can continue along with basal insulin. Basal insulin is usually prescribed once a day. Sometimes we can give it twice a day as well. The ultra long acting insulins will always be given once a day. Degludec, Glargine U300. The long acting ones are usually given once a day. Detemir and Glargine U100. Intermediate acting insulin like NPH can be given once or twice a day. So, depending upon the need of the patient, you may wish to give it once or twice daily. How do you combine with drugs? Each and every oral drug can be combined with basal insulin. But with pioglitazone, we need caution because there might be fluid overload, weight gain. When you give sulfonylureas and basal insulin, it's a good idea to be cautious and not to up titrate the dose very fast. So, all OADs can be used along with basal insulin. Be a bit cautious with pioglitazone. Go slow with sulfonylureas. And whenever we use OADs and basal insulin, the total dose of insulin comes down. So most OADs have an insulin sparing effect. Now, basal insulin is used in patients where fasting glucose is very high, where the postprandial excursion is not all that high. But there may be some patients who require both fasting and postprandial coverage. Such patients can use premixed insulin once a day or twice a day. For those patients where we use premixed once a day, we can use uh, biphasic human insulin 30/70 or 50/50. We can use biphasic aspart 30/70 or 50/50. We can use biphasic lispro 25/75 or 50/50. Or we can use co-formulation insulin degludec aspart. Any of these can be used once or twice daily. How do you combine with drugs? We can use with all OADs. But two cautions. One, pioglitazone, use with caution, be careful. Secondly, if you wish to prescribe premixed insulin once a day, you can use a sulfonylurea, but at the antipodal meal. Antipodies means like the antipodies is Australia and New Zealand, the southern hemisphere. So if you're giving your insulin with breakfast, then the antipodal meal becomes dinner. If you're prescribing once daily insulin before dinner, then the antipodal meal is breakfast. So again, same rules as for basal insulin. All OADs can be used. Be cautious with pioglitazone. Be cautious with sulfonylurea as well. Do not give a premixed insulin and a sulfonylurea together at the same time with the same meal. Most patients who are put on basal or premixed insulin once a day will sooner or later require premixed insulin twice a day. This is again because of the natural history of disease. Gradually, insulin secretion will come down. There will be greater secretory defect. So we will need to replace with more insulin. Now, premixed insulin twice a day can be used with all drugs, all oral drugs. For pioglitazone, more caution is required. Be very cautious. Do not use sulfonylurea or repaglinide at the same meal as insulin. However, if you are giving premixed insulin twice a day, maybe breakfast and dinner, and you need coverage for lunchtime, this is quite frequent in our practice. Patients say, I cannot carry my insulin to my workplace or I want to avoid disclosure. Then we can use a short acting sulfonylurea like glipizide 5 milligram. We can use a short acting secretagogue like repaglinide 0.5, 1 or 2 milligram. Usually 1 or 2 milligram will be required. This is given with the non insulin covered meal. You can also use acarbose or voglibose to potentiate postprandial control. Acarbose 25 or 50 milligram, usually 50. Voglibose 0.2 or zero point 0.3 milligram. I use these combinations quite frequently. Patients who are on premixed insulin twice a day, who actually need basal bolus therapy but are not willing to take it, who are not willing to take a lunchtime dose of insulin, patients with corticosteroid induced hyperglycemia who just give up and say that I cannot take an insulin time lunchtime insulin. So the drugs that I use commonly are metformin plus acarbose, metformin plus repaglinide, or metformin plus glipizide at lunchtime. Glipizide is the most economical. Acarbose would be the best when it comes to postprandial control in such a situation. So we've talked so far about OADs and basal insulin, OADs and premixed insulin, OADs and premixed insulin twice a day. For all these, the commonality is caution with pioglitazone, caution with sulfonylurea. You can use insulin and sulfonylurea at different meal times, but not at the same meal time. Now, there will be some patients who will be on a basal plus insulin. This means basal insulin once or twice a day, plus 1 or 2 or 3 doses of prandial insulin. Same rules as we had for premixed. If you're giving an insulin with any particular meal, whether it is breakfast, lunch, or dinner, the patient does not need a secretagogue at that time. So the patient will not benefit from a sulfonylurea or a repaglinide at the same meal time. However, you can use short-acting sulfonylureas or repaglinide at different meal times. Pioglitazone, again, caution is indicated. And let us say we are giving uh, prandial insulin with breakfast and a basal insulin. There is no harm in writing a sulfonylurea or a paglinide for lunch or for dinner. Do be aware of the pharmacokinetics of the sulfonylureas. Glimepiride and glyclazide XR are long acting. Repaglinide, on the other hand, which is not a secretagogue, it is a secretagogue, it is not a sulfonylurea, and glipizide, these are short acting. So be aware of the pharmacokinetics when you decide the timing of administration. Now, there will be some patients who will be on basal bolus therapy. All people with type 1 diabetes ideally should be on basal bolus. In type 1 diabetes on basal bolus, some patients may benefit from metformin. And you will find a relatively higher number of patients with type 1 diabetes on metformin. Why is metformin prescribed? This is because the doctor thinks that these people may have something known as double diabetes. Double diabetes means that the patient has type 1 diabetes, but also has symptoms, signs, stigmata. Symptoms, signs, stigmata of insulin resistance. So if you find that a child with type 1 diabetes is gaining weight very fast, developing acanthosis nigricans over the neck, having darkening of skin, maybe development of skin tags, developing cardiovascular complications or risk factors, it would not be a bad idea to start metformin along with basal bolus insulin. At the worst, metformin will not act. At the best, it will bring down insulin resistance and will reduce insulin dose requirement. Now, basal bolus insulin in people with type 2 diabetes. This is relatively common and it's increasing as complications increase. If your patient has severe hepatic or renal impairment, that is why basal bolus was started, then no OADs make sense. Uh, in renal impairment, the safest would be linagliptin, 5 milligram OD, which you can give up till an EGFR of 1. Same for hepatic impairment, mild and moderate. In few patients, if the EGFR is more than 30, you might wish to give metformin. But otherwise, if your patient is overall uncomplicated, there is no hepatic, renal, or cardiac impairment, then we can use any OAD except sulfonylurea and repaglinide with basal insulin, which means we can use metformin, we can use GLP-1RA oral or injectable, and we can use SGLT2 inhibitor. And pioglitazone should be used with caution. In general, we should try to initiate insulin as early as possible and optimize glucose control. Insulin prescription should be accompanied by education and awareness. But because prescribing insulin is a bit tough, it makes sense to use easier or relatively person friendly methods of giving insulin. These include basal as well as premixed insulin. But there's always an inertia or a hesitancy when it comes to prescribing insulin. How we can overcome that is, let us say the patient is feeling comfortable. There is a comfort factor. I have been taking these drugs for the past so many years. You say that my HbA1c is high, but I am not feeling bad. So the comfort factor is you keep those same medications and you add insulin over and above. So when you're adding basal insulin, then there's not too much of an issue. The previous drugs will continue. If you're adding premixed insulin, you may have to take out 1 or 2 doses of sulfonylurea, depending upon whether you are giving 1 or 2 doses of premixed insulin. And this way, you are able to overcome the hesitancy, the insulin hesitancy. So do be aware that every prescription carries a comfort factor as well. Don't snatch the comfort away from the patient. Patient tells you, I've been taking a tinolol amlodipine combination for 20 years. She's doing fine. Irrespective of what the book tells you, don't stop it suddenly unless there is patient is in real distress. Patient has got a bradycardia, heart rate 40, or patient is in very symptomatic heart failure. Then you stop the atenolol, not otherwise. Similarly, patient says, I am doing very well on glimepiride and metformin. I don't want to stop. Listen to the patient, listen to the unsaid needs, and just add a basal insulin along with that. And this will allow early transition to insulin and also will prevent complications. Whenever we are starting uh, insulin, especially basal insulin, be smart. That is basal enhanced smart therapy. And these 7 T's that we have to remind our patients about. First of all, begin the treatment with insulin and the oral drugs. Secondly, the timing of insulin, how to transport insulin, store it at home, how to take it, what is the technique of administration, what targets should we set for our patients, what tablets should we give and not give, and what are the tools for monitoring and troubleshooting. So, this 7T concept, let's go through it one by one. When you are initiating insulin or any other treatment, speak to the patient about the importance of timeliness. The early bird gathers the worm. The early bird gets the worm. A stitch in time saves nine. Penny wise, pound foolish. Metabolic karma. Ganga Jal taken in time is life saving, but taken at the end of life has no value. These are some ways to motivate your patient to initiate insulin in a timely manner and involve them when you are treating them. What is the timing of administration? Some insulins have to be given at a fixed time, others have got a lot of flexibility. For example, injection degludec can be given any time of the day, and the gap can be as little as 8, as much as 40 hours between two injections. Glagin U300 can be given with a plus minus 3 hour gap. The others have to be given at the same time. For rapid acting injections, analogs can be given 5 minutes before a meal, while human insulins have to be given 30 minutes before a meal. And the ultra rapid acting insulins like URLI, early, ultra rapid acting Lispro, and FIASP, fast acting aspart. These can be given up from 5 minutes before up till 15 to 20 minutes after a meal. So there is a lot of flexibility with the newer analogs in terms of timing of administration. Treat to target, you must put the targets for your patient, fasting glucose, PP glucose. It is always a good idea to give a reality check. So, madam, we are starting this insulin. You will begin to feel better in 3 to 4 days. Don't worry, your symptoms will improve. Your glucose will come down after 10 to 12 days. So, give a range to the patient so that the patient doesn't feel upset if glucose doesn't come down in 5 days. Tablets, like we've said, we need them. And usually we will continue metformin. Glitazones, we should be careful. Alpha glucose inhibitors we can give if we want postprandial control. You can actually, there are studies, you can add acarbose to premixed insulin to improve the postprandial coverage. SGLT2 inhibitors, DPP4 inhibitors, and GLP-1RA all help in reducing glucose, in reducing the dose of insulin, and GLP-1RA and SGLT2 inhibitor help in reducing weight as well. So you also should have a protocol for managing hypoglycemia. To some patients, usually you may say if you're taking a sulfonylurea tablet, if it is a squad tablet, you can break it into half or you can stop it. To others, you may say just reduce the dose of insulin by 4 or 6 units. So that will depend upon the prescription and the numeracy level of the patient. It also depends upon how frequently the patient can contact you for follow up. But whenever you write an insulin and sulfonylurea together, do tell the patient how to reduce dose if hypoglycemia occurs or even if it is suspected. I now have begun preferring fixed dose combinations, which are scored tablets. They are available for both glimepiride metformin and for glyclazide metformin. So, if you use a scored tablet, it's very easy to tell the patient just break it into half if you feel that you have hypo. Now, let's come to our questions for today. Which oral drug should be used with caution in insulin? We've mentioned it again and again today. So, our question is for which oral drug do we uh, keep maximum caution levels with insulin? Is it pioglitazone, GLP-1 RA, acarbose, or sustained release metformin? So, for which oral drug should we practice maximum caution with insulin? A. Pio, B. GLP-1 RA, semaglutide, C. Acarbose, and D. Sustained release metformin. Our second question: which oral drug can be used to provide post-lunch coverage along with twice daily premixed insulin? Will the post-lunch coverage be maximized with A. Pioglitazone, B. GLP-1 RA, C. Acarbose, or D. Metformin sustained release? So, for post-lunch coverage along with twice daily premixed insulin, if you wish to add an oral drug, should it be Pio, GLP-1 RA, Acarbose, or sustained release metformin? With this, we come to the end of today's talk. Uh, I understand that there are many questions, but I would like to take your leave today. Please allow us to discuss all these questions next week when we meet again for FDC Diabetes Essentials. I'd like to thank everyone for a patient hearing. Thanks for being with us, and I look forward to meeting you again next week. With this, I'd like to hand over back to Team FDC. Thank you and Jai Hind.
I would like to thank Sanjay sir to give such thought-provoking and interesting talk on the topic. And I would like to also thank all the doctors to attend every Sunday with such enthusiasm. I would like to thank all the doctors for it. Next, with the same energy that we will again rejoin at the same time at 9 p.m. on Sunday evening. Till then, Jai